Welcome to today's session of Conversations with Leaders with our guest speaker, Niyum Gandhi. Thank you so much for making time for us here today. He is the Executive Vice President, Chief Financial Officer, and Chief Population Health Officer. So, first off, congratulations on being promoted to the Chief Financial Officer last year. I have to ask, when you went to update your ID badge, did they have trouble fitting all the titles? Did they truncate it? Did they say, listen, you have to pick one because we don't have enough characters? So
So
how did that
I
go?
actually had that problem when I first got my ID badge because it was just Executive Vice President and Chief Population Health Officer. They typed it in, and the woman who was filling it in, she looked at me. She's like, "That's too long. Can I shorten it?" And I said, "Whatever you want to shorten it to." So here it just says Executive Vice President,
Okay.
nothing else. And I guess that still works. But yes, I did have that issue.
Perfect. It was funny because when I saw it, I was like, I have to ask that question and see what he experienced. So great, great, good to know. All right, so just to kick things off, I'd like to start out with the direct question, of course, of where you're from, right? But to be a little bit more direct, tell us about where you were born and how your parents' ethnic background had an impact on your childhood.
Yeah, I was born in State College, Pennsylvania, which is right in the middle of the state and kind of in the middle of nowhere. And like to illustrate how middle of nowhere, the house that I lived in from when I was born to when I was 5 was literally next to a cow pasture and a dairy farm. Like that. That's how much the middle of nowhere. Um, but it's a college town in kind of in the middle of nowhere in Pennsylvania. And my parents, who are both immigrants from India, it's where they moved right after they came to the U.S. My dad went to grad school in Pittsburgh and got a job as a pharmacist in State College. And they gave him a choice between two towns he had never heard of in the middle of Pennsylvania. And he said, okay, that one sounds interesting. Let's go. Yeah, so I grew up there. As I mentioned, my parents are both immigrants from India. When I was young there, I would say there were probably 20 or so Indian families in State College. There are now like 300. I would say my parents' ethnic background, probably the biggest impact for me was it created a community for me, and not that it was it's interesting. It was a community of all of those 20 Indian families who all knew each other because there were only 20 of them. And the fact that they were all of Indian origin wasn't actually the purpose of the community. It was just, new person moves into town, they're of Indian origin. Okay, suddenly there's, 20 other families who they know within 2 weeks. And so it was almost like the shared ethnic background was an excuse to have a group of people that we spent time with. And so when I was growing up, the two communities I was most part of were that and my neighborhood. Right? There were 20 houses in my neighborhood. We were the only Indian family there, but it was that group of 20 families and then the 20 families that were in the neighborhood. And so that it created a sense of community for me that persisted all the way through. And even now, now it's 300 families, and my parents know all 299 other ones, and and they're the older ones in the community now and welcoming new families in. And so, it was like I had I don't know, like a homemade group of friends who who I would see, at various events or functions or just, at other people's houses. And that was a nice thing to have growing up.
Okay, that's great. So as you start to go through school and you start to be introduced to new ethnic groups and people from diverse backgrounds, uh, how was it interacting with them while also chasing your career path?
Uh, yeah, it's, I would say probably as to kind of break it into stages of my life, unfortunately, growing up, not a ton of diversity that I was exposed to. And so that's, I'm not trying to be like, pejorative about where I grew up. It was just there was probably not a great understanding and appreciation of differing backgrounds and, ethnic, racial, or other types of diversity. So I got introduced to a lot more of that when I went to college. And I think that was actually that was a great experience for me, of all sorts of, again, all sorts of different diversity. Going to, I went to Harvard, so kind of a liberal arts sort of background college that's pulling from all over the country and all over the world in that way. I think that's probably when I got a better appreciation for the fact that there was so much I could learn in any conversation with anybody who had a different set of lived experiences than myself, which could be based on ethnic background, racial background, where they grew up, what sorts of challenges they faced growing up versus the types of challenges I faced. That I thought was actually really valuable, especially as I then started thinking about career path, because it opened up ideas to where I would live, or what type of job I might be interested in a way that I think if I would have just had my previous focus from 0 to 18, I would not have necessarily had.
All right, definitely. So you're in college now. Do you already know that you want to pursue a career in finance? Is that something that developed in college? Tell us about that.
Yeah, so I decided I wanted to pursue a career in finance 11 months ago when Ken asked me to be the CFO. When I was in college, I was an econ major, so I was generally, I guess, maybe, and it came honestly more out of an interest in math. I like numbers. I've always liked math, and so it was like, but I didn't want to go into the hard sciences. The one thing I knew I did not want to be was a doctor. My brother's a doctor, and my older brother, he loves it. He's great at it. But I was like, oh, he already did that. I want to do something else. So I was thinking social sciences, something with numbers, landed in econ, and really had no clue what I wanted to do. And so I joined a consulting firm out of college. And the advice that I got from someone, actually the family who welcomed my parents to state college when they were in their 20s, was it's a family who was like 15, 20 years older than them. Their son was like a mentor to me as I was growing up. He's also of Indian origin, and he said to me, he's like, until you're 30, you should make all your career decisions based on where you think you can learn the most. And he said, just, you're going to have to optimize on so many things: where you want to live, income trade-offs, things that are important for your family, all of that. And you're going to have your whole career to optimize on all sorts of different things. If you focus for your first, 5 to 10 years of your career on learning the most, you'll have that with you forever. Because I was asking, what should I do? I have no clue what I want to do. And he was like, just pick a job where you think you're going to learn. And so that's why I, ended up in consulting and kind of landed in healthcare based on the people who I wanted to learn from, who were these, great partners at our firm who I'm still in touch with, today. Who I, really felt like I got along with well, who I could learn a ton from, and they happened to be doing healthcare work. And so then I ended up doing healthcare. And so that's how I ended up there.
Yeah, that's great. I think that's a lot of our issues, like trying to formulate a plan, execute the plan. Is it too early? Is it too late? So to hear that, you're in college and you're just like, okay, where am I going to go? What am I going to do? But that's a great point, having the best resources, living in the best place. I remember I was told at one point, you want to pick the right boss because you want to make sure that this is someone that's going to mentor you and really nurture your growth.
Yeah, I think that's absolutely right. I was actually reading about that. It's something roughly, around the numbers, because I don't remember the exact ones, but about 75% of people when they leave a job leave because of their boss. Only about 25% of people when choosing a job choose their boss. And I'm totally with you on that one, Sean, that actually, if you think about where can you learn the most, you're going to learn the most if there's a boss who's invested in you, who's going to coach and mentor you and make sure that you're learning. And then that's stuff that you have with you for the rest of your career.
Yeah, absolutely. So I want to get into your role as the chief population health officer. So you've been directing this strategy for the last 5 to 6 years, correct? All right. So for those of us who may or may not know what population health is, can you give us a high level definition of what it is and what strategies are being implemented here at Sinai to push forward that value and risk based initiative?
Yeah, the general idea I would say is that traditionally healthcare has been paid for in a really transactional manner. So it's you provide a service, you get paid for it, whether it's the hospital or the doctor or whatever else. I think the challenge with that is that really promotes a really good sick care system, not a great healthcare system, because when you're sick, you need treatment. You get whoever's treating you gets paid for treating you, and then you're on to the next thing. But when you're trying to manage your longitudinal health, that's not really it doesn't make sense to pay based on encounters when what we're talking about is you want a healthy life. The interventions may not be things that have a CPT code or can be billed in a certain way. The intervention is engaging with somebody and being their partner in their health and wellness journey through life. And so, the way we think about population health here is that it's the combination of the clinical, operating, and financial model that fit well together around promoting healthcare. And so there are ways that we can change how we contract, and we take risk for populations where we get paid a fixed amount for a group of people, and it's irrespective of how many services they receive. And so if you think about that, the most expensive services are when you're really sick and in the hospital. And so if we can spend $100 keeping somebody healthy so that we never have to spend $10,000 treating them when they're sick, that's good for us financially. It's really good for them healthcare wise, right? Because we spent money to keep them healthy rather than never letting them, end up being sick. And so that's an oversimplified model of it, obviously, but there's these contracts that we enter into with the health plans to get paid for risk are like 200 pages long, and there are people who are way smarter about that than I am who get into all the details. But to do that, then you need the clinical model as well. And so you need to invest in resources, care management, social work, community-based organizations, other partners that are going to help us play that role, because it's not just the doctor, right? If a patient is struggling with self-managing their diabetes, and sometimes they miss some of their medications, or they aren't eating the way that they need to keep their diabetes under control. It's not like they come in to see the doctor and the doctor says, well, you need to exercise more, sleep more, eat healthier, and make sure you take this drug, and then suddenly it changes. That's not the way the world works. If it were that easy, then we wouldn't have a population health problem. So we have to, meet the patients where they are, help them, provide resources, help educate, but also help address gaps that may exist. Maybe the reason that they aren't filling their prescriptions is because they don't have the money for the copays. Maybe the reason they're missing their appointment is because they, can't get to their appointment. They have transportation issues. Maybe the reason they aren't eating healthy is because we aren't giving kind of culturally contextual guidance on what a healthy diet for their disease may look like within their community. And so investing in what we need to help change their health trajectory, and using basically the money that we save when we do keep them healthy by avoiding hospitalizations and surgeries and other expensive things that are used to treat the illness. If we can prevent the illness to begin with, that's the general premise of it.
Right. Thank you for that. It's interesting because I believe 2 years ago, my colleague Frank Pabon, he was always talking about when patients come in to see the primary care doctor, do they get questions about anything as far as social determinants and how that may affect their health? And we've always wanted to do a panel, and I know this is probably a shameless plug to put out the next event, but we always wanted to know if that was a part of the process. And we know there may be some sort of HIPAA laws or political issues as far as how you ask that question to a patient, right? But in hearing your explanation of the value-based model, it seems like that's a critical piece to that.
It absolutely is. And so we've started integrating that into the work that we do with the patients who get their primary care from us. Interestingly, very often, the primary care physician is not the best person to ask those questions. For a lot of our patients, the primary care physician that they meet, it's a little distant. They're wearing the white coat, right? It may be the highest educated, wealthiest, and most intimidating person who they interact with on a regular basis. That may not be the right person to ask the question. And so we work with community health workers. We have our social work team. We have coordinators who are involved. Often we try to, when possible, hire from the communities that we serve, and match those people up with the patients who may have some challenges around some of the social determinants of health. Have it come out in a conversation, in a productive conversation with somebody who is really engaged, who's using motivational interviewing techniques to get the information, who's empathetic. Not that physicians aren't, but the physician needs to be doing what the physician is doing. And so it's not always the highest and best use of the physician's time, but actually, it's not just saying, oh, well, the physician should be doing doctor stuff and somebody else should be doing this. It's actually, in the same way that the physician is trained to do certain things, there are other people who are trained to have these conversations and get that information. So we do capture the social determinants information, and then actually we use that to refer patients to organizations or partners that can address some of those issues. The same way that a primary care physician, if you have a heart problem, refers you to a cardiologist. If you have a food insecurity problem, we're referring you to an agency that can help you with that.
Excellent. It's great to know that Sinai has those resources. So definitely looking forward to where that actually goes. So we know that there's disparities in healthcare towards minorities, and there's this segregation of practices. This has been a hot topic throughout the years for healthcare institutions around the globe. And to add some context to that question for our attendees, a patient that presents a Medicaid managed care plan may not be afforded the same care as a patient who may present with a commercial benefit plan. So what strategies do you feel can be put in place to tackle this? Because we know that reimbursement is essential to operation, but to your point, we're here for patient care and making sure that we have that longevity.
Yeah, this is, you're right. It's gotten increasing attention, in the past couple of years, but this has been a problem for, forever. Maybe just to start, and I promise I'll turn more towards positive of what we can do in a minute here, but I think it is worth noting that so set aside any individual healthcare provider for a minute, the entire structure of how healthcare is paid for at the most macro level is systemically racist, right? Because why are payment rates higher from a commercial insurer than a Medicaid managed care plan? It's like, well, because an employer pays a commercial insurer $6,000-7,000 per person per year for that care. The government pays a managed Medicaid insurer a little bit more than half that for a Medicaid patient. So that literally, in the way the dollars come all the way at the starting point, we're saying that certain patients' healthcare needs are worth less than other patients' healthcare needs, right? And that's, again, it goes back all the way to how Medicaid is funded, this patchwork quilt of a little bit of federal money and a little bit of state money. And if the state decides to spend more, they get a little more federal, but only up to a certain amount. And, all I can say is, candidly, it's so much worse in so many other states than it is in New York, because New York has decided as a state, the voters in New York have decided to fund Medicaid more, but it's still not funded adequately. And so it creates this really awful set of downstream cascade by which no matter what role you play in care delivery, there have been fewer resources allocated for certain populations than others. And it goes against any idea of healthcare being a fundamental human right or being something that should be provided high quality, equitable healthcare should be provided to all people. And the way that we stitch everything together as a society in the US is just not that. So in a completely imperfect world where the top level funding sources value the healthcare of certain populations higher than others, what then can we do at the tail end to try to address that, right? And so we're living with certain constraints. So what can we do? Well, one thing we can do is, we can continue to advocate for change in healthcare financing so that, that changes that. There's a bunch of small things, but there are bigger things also. And, whether it's, changing how healthcare is financed at the macro, federal level, or, there's some states that have looked at basically taxing commercial revenue for healthcare providers and using that to increase Medicaid reimbursement rates. And it's a rather clever way to say, okay, we know that as a state, we can't change how things are funded federally, but we could tax the providers on their commercial revenue and just use that to boost Medicaid rates and, equal it out this way, which will make it easier for providers who want to do more of the right thing and provide more equitable care, regardless of payer status, to do that. And so we're exploring some of that and what that might look like from an advocacy agenda. And then, that's slow and not enough, right? So what can we do on the ground? And I think the key we need to do on the ground is say, we're going to take in as many patients of whatever payer status, irrespective of payer status, as we can, right? And so there's a finite set of resources available, but we need to open the doors as much as we possibly can to as many patients from the communities that we serve as we can, regardless of payer class, and then ensure that the standard of care that we have, both for access and for quality, is the same. And we've made some progress against that in the past handful of years, but we still have work to go, right, on that in terms of ensuring that it truly is integrated, seamless care across the care continuum, from primary care to specialty care, not, certain clinics for, patients with certain insurance and certain practices for patients with other insurance, right? So, a lot of the work I'm at 98th and Madison today in the, in the Icon building here. So a lot of the work, across the street in the CAM building, great work that the Mount Sinai Hospital leadership has done there is actually moving practices from the old faculty practice space into the CAM building space so that it can be fully integrated, open to all patients of all insurance status. And it's like again, we're trying to play the game with one hand tied behind our back because of the federal and state funding. But, some of what we've tried to do there is get creative and say, okay, well, how can we, despite the fact that we're playing the game with one hand tied behind our back, how can we, make sure that we're still able to win in our effort to provide the same care in the same site for all patients, irrespective of payer class. And so again, more work to be done, and there are a lot of people focused on that at the ground level. But we provide care in 400 different locations across the greater New York City market, and the work needs to be done at the individual site-by-site basis of, what can we do to change how this site operates and, move along in our journey there.
Absolutely. I can imagine how intense those discussions can get because it changes a lot of cultural aspects as far as billing and reimbursement. So it'll be interesting to see how that goes along. So I just want to rewind the clock back 2 years. It's the beginning of 2019, and at least from the CBO standpoint where I work, Mount Sinai is thriving. There's so many innovations clinically at the school, at the practices. Then 2020 comes, and COVID hits us like a Mike Tyson gut punch, and it just throws everything out of whack, and everybody has to transition. Telehealth, social distancing become mega words as far as our ear. As far as from a financial strategic standpoint, what measures did you think that we took that really worked and had us prepared for this, or what can we do better to prepare for the next crisis, because we know history repeats itself and we may be faced with something like this again?
Yeah, it's a great question. I would say one thing that we had done that I didn't even realize perhaps that we had done. It's not so much we had done; it's kind of the culture of the organization had been created. Uh, I was blown away by how nimble our 42,000 people were when, like you said, Mike Tyson gut punch, right? And just a small example. I remember on March 1st. So we diagnosed our first COVID patient on February 29th. On March 1st, our system executive team meeting, the topic for the meeting, completely coincidentally, was a work from home initiative.
Mm.
And because the employee base has been growing, there are more and more employees, even pre-pandemic, who are saying, I'd love to be able to work from home a couple of days a week or maybe full time. Long commute, you chop 2 hours off of my work day. If I don't have to commute for an hour in and an hour home, I can be more productive for the time that I'm working. I can get more time with my family. Maybe I don't have to live in, a smaller place close to work. Maybe I can move out to the suburbs and, have a little more space for my family. So we've been getting a lot of requests about that. And, it's where the world is going, even, again, pre-pandemic. And we had a conversation about, okay, what would it take? I think we had under 500 people working remotely before that. We had a conversation about getting to 2,000, right? So that was the target. And I remember being in the meeting and somebody mentioned, we're going to have technology challenges doing that. And they went through actually something I didn't entirely understand, some details around, our ability to have that many people working remotely at a time, and what we had in terms of the VPN capacity and whatever else. And so Ken, said, okay, well, how long is it going to take before we can, accommodate 2,000 people effectively? And I said, okay, June. All right, great. 3 weeks later, we had 9,000 people working remotely, right? So the plan was figure it out over 3 months to get 2,000 people, and instead everybody just busted their butts and got 9,000 people working remotely in 3 weeks. And like that, there were dozens of examples like that where people across the organization just stepped up, thought creatively, set their egos aside, figured out new ways to do things, and it just got us all, doing what we needed to do to fight the pandemic. And that, whatever, confluence of events created a culture here such that everybody just did that. I mean, that is amazing. And I can tell you, it may be easy to say, oh, but anybody would have done that. It's not true. I talked to colleagues around the country. There are plenty of health systems that did not have that experience. I think in New York, more often than not, most of the health systems did have that experience. I think our culture is actually somewhat shared by some of our fellow organizations around here, but there are plenty of organizations that just flat-footed when this happened. So that I think is one thing we did well. I often think about what can we do better to ensure that, to your point, that we do better next time. And I think it's the soft stuff especially. So, and one example is we had a lot of people who had to play out of position for, all of March, April, and May. Probably everybody who's on this webinar had 2 or 3 jobs for those couple of months. And probably only one of those jobs was even remotely related to what their normal day job was. Yep. And again, we pulled through and everybody did a fantastic job. Well, we should be thinking about that in our training, in our hiring, in our promotion practices. So to be a more resilient and nimble organization, we should focus on embracing things like diagonal promotion. Healthcare is awful at that generally. It's very siloed. If you're the if you're the supervisor of X, you get promoted to be the manager of X, and then the senior manager of X, and then and that's very much how healthcare is wired. Most other industries are not. There's a lot of, okay, you're the supervisor of X. We see some talent in you. Well, we're going to make you the manager of Y. That has nothing to do with X, because your talent has nothing to do with your content knowledge there. Your talent is that you're a good candidate for management, and you're going to learn new content quickly. And then we actually recognize that by the time you get up to the director level, you've touched 5 different parts of the organization. And I think Mount Sinai does this better than many healthcare organizations, but we could learn a lot from out of the industry to say, what can we do to build our team, our culture, all of our workforce to be more, multi-position players, partly because that will be useful for everything we want to do. It engenders better collaboration and, better cross-functional thinking, but also the next time because the next time it happens, it won't be an infectious disease pandemic that looks like X, Y, Z. It'll be something else, right? Like you said, history repeats itself, but it doesn't repeat itself in exactly the same way. So we can't, if we spend too much time preparing for the next, COVID specifically, we're going to miss, out the side view that the next thing is actually going to be something completely different.
Right. Yeah, definitely. And I think this is a perfect time to give that recognition to everyone who did step up. And I'd like to bring up the book, The Leader Without a Title by Robin Sharma. And I think everyone took on that form during the pandemic. Everyone stepped up, and we really got to see some strong mental fortitude from our workers and our leaders. And, we thank you all, because from the doctors, the nurses, the person checking the patients in, to the person taking the blood, to the person making sure that everything is sanitized. I mean, it was just such a transition. All of our workers who went remote without a hitch and kept everything going and productive, and the performance at that, I mean, it's just incredible. So thank you to all of you, because you made it happen, and that's something special. So we also know last year wasn't just COVID. There was a lot of ethnic tension with racism and bias, the killing of George Floyd, the killing of Breonna Taylor, the Black Lives Matter movement, who actually just got nominated for a Nobel Peace Prize. So me and you worked on the task force together, and I'd just like you to share, what was your experience like being a part of those conversations for 5 months, and what is, I know we can't reveal too much, but what would you like to see happen, hopefully within the next year or so, as far as those initiatives?
And so, in terms of my experience, the first thing I would say is, for anybody else who was involved with the work, thank you, because I learned so much through the work on the anti-racism task force with folks like you, Sean, and others, and I would say for me, probably and I know we probably all know and love him and talk about him a lot, but the person who was most impactful for me was Gary Butts, who spent a fair amount of personal time just one-on-one with me. We happen to live in the same building, and so we had socially distanced meeting out on the terrace of the building. Nobody else wanted to be out there, so it was good. We had enough space to sit far away from each other and chat. And I went to him with the question right before we kind of kicked off the task force work, and I said, Gary, I know I'm not doing enough as a leader, and would you be willing to give me some honest feedback? And if I talk to you about some of the things that are on my mind, share with me, your perspectives and from your experience. And he was generous enough to spend that time with me, and then create a safe space for me and myself, Jeremy, Bowl, Art Gianelli, and Gary meet every Friday, and that is my safe space group to ask questions and learn, and I think the others feel the same way as well. And so between that and the task force, I think understanding, I would say I had a high level, like 100,000 foot understanding of issues around systemic and institutional racism in the U.S. I knew the language, I knew the words, I knew the definition at the one sentence level. I would say I certainly did not do a good enough job introspecting, and I still have work to do here on my day-to-day actions and the impact that they can have, and that if I am not being explicitly anti-racist in my actions and the policies that I'm influencing, and the work that I'm doing, then I am contributing to the problem. And so that for me was probably the biggest, kind of selfishly, the biggest personal benefit of having the opportunity to participate in the work of the task force. And and I think hopefully with enough of us having the exposure to that dialogue, it helps us. To your point about what do we have to look forward to in the next year, and you're right, everybody will see it soon enough, and I don't want to reveal things I'm not supposed to, and I know you've probably been struggling with the same thing, but I think that the group put a lot of effort into thinking about the right strategies and right interventions for the organization to take on to address challenges in our organization, challenges in our community, challenges amongst our patient base, and really with the North Star of being a learning anti-racist organization. And so there's some great stuff that I think has been thought through. The thing I'm most excited about though is it's the micro decisions that everybody makes every day. Right? So there's 11 strategies with 70 some interventions, and there's some work done for each of them. It's the 500 decisions that each person makes every day. And so the more I'm really looking forward to continued progress in creating a culture such that we make better anti-racist decisions, all of us, in all the small things we do every day, and seeing the impact of that over, and it's going to take years, which sucks, but the impact of that over years in the organization, that can only come from a commitment to humble learning about our failings to date.
Absolutely. I think the great thing that you said was the safe space and allowing and also educating our leaders to actually have those tough conversations with their teams and be able to become great listeners to eventually impact change. And yes, a huge thank you to Dr. Butts, Pam Abner, all of the task force members. I've learned so much from everyone over the last 5 to 6 months. And like you, I'm very excited for our future and our strategies to actually be shared with everyone. Two quick questions before I open it up to the group. If you could title Mount Sinai Health System's resilience last year after a movie, what movie would you pick?
Oh, title it after a movie. All right, let me think about that in the back of my head for a minute while we hit the other one, and I will answer it at some point over the next 19 minutes before we drop off. But I want to make sure I get that one right. That's a great question.
All right, no problem. So, with everything we've discussed today, encompassing value-based, risk-based model, the population health strategy, the racism and bias strategies, and how we look at healthcare going forward, where do you envision Mount Sinai Health System going? And what's your vision, I should say, for Mount Sinai Health System?
Yeah, so I think that the path that we're on, and that I think we will be able to achieve, this vision, and we'll never really achieve it, because if we, as we get close to achieving it, we should set the goalpost further away, right? Because we got to keep having forward progress. But I would say I want us to be the highest value healthcare organization in our market. I'm going to define value here as as outcomes over, some measure of cost or whatever, right? So it's like, somebody's paying for the healthcare, the government, employers, whatever. And then that outcomes piece is important. And I would break that into quality, experience, and equity. And so we should be the highest quality, the best experience, with the greatest equity in everything that we do. So, and you can measure that, right? You could say, all right, our quality outcomes are X, Y, and Z, and we should change those quality outcomes, right? Because once we're performing best on something, we should add new ones. But you could come up with a long list of quality outcomes. You could come up with a long list of experience outcomes. And then the equity one, I think, is really critical to measure, and we're starting to do that. A little spoiler alert, that's part of the work of the task force, is to, create better definitions around some of this and actually embed it into everything that we're doing. I don't think I'm, sharing anything that's too secret there. But if you look at quality outcomes for a population and quality outcomes for a different population, and there's differences there, that's inequity. And what is unacceptable is to say, oh, well, that inequity can be explained by things that are outside of our control. That may be true. It may be driven by things outside of our control. So if I pick on, one of the classic population health measures when we look at, quality scores for diabetes patients, hemoglobin A1C control, right? And so, what percentage of our patients with diabetes have an A1C in control? And if it's, 85% for our white patients and 65% for our black patients. And if we say, oh, well, that's because, our black patients are disproportionately lower income and they don't have access to XYZ resource. And okay, well, that's BS, right? Like, no, the answer is different communities that we serve and different populations that we serve are going to need different resources to get to 100%. And so the work that we need to do to get both of those numbers up is different, but the goal should be exceptional best-in-class outcomes for all subpopulations that we could, however we can cut it. And that's equity and quality at the same time, right? And so, my dream would be, and we have to prioritize where we're going to focus, because if we try to move, 1,000 metrics at the same time, we're going to move none of them. But to go through, pick the highest priority ones, keep moving them across the entire population that we serve, with an eye towards also being the highest equity healthcare organization, which should be embedded in our definition of quality and experience and value, every time we use it. And I think we can get there, because I think we have a lot of great work that's been done to date. I think we have very committed leadership. I think we have a committed board to helping us get there, to demanding that we get there. And I think we've made some greater investments in each of those definitions of value, each of those subcomponents of the outcomes piece of value over the past 5 to 10 years than many others. So we have a good kind of platform to go from. But if 10 years from now you ask a random person on the street anywhere in New York, who do you trust with your healthcare? I want them to say Mount Sinai.
Right. Great statement. All right. So we're going to open it up to questions. If you have a question and you've already written it in the chat, that is fine. But if you have one, please put it in the Q&A section. So the first question we have here is, what are your thoughts about how Biden's plans will move our institution?
So, I think a few things. One very tactical, small thing is, is the bill that they're working on right now involves a lot of, if passed, supports a lot of state and local relief from COVID, which is so critical. And we were worried would not, kind of make it into the agenda, pending how various parts of the election turned out. And, now is squarely part of the agenda. New York got hit really hard. And unlike some other communities, when it got hit hard, the state government and the city government jumped in and poured a bunch of resources into helping. And that's leaving them hurting financially right now. And the problem is that when the state is hurting financially, it's really hard for them to balance the budget because the biggest line item in their budget is the Medicaid budget. And so, when we talk about the systemic racism of how healthcare is financed, we could end up in a situation if the state doesn't get some support where the only lever they can pull is reducing Medicaid expenditures, which, would just be awful for us as an organization and awful for the communities that we serve. And so, fortunately, I think that's going to get addressed, and I think that's a big part of Biden's agenda and the Democratic Senate's agenda as well. More broadly and longer term, I am hopeful that the ACA is not a perfect piece of legislation by any means. I am hopeful that under President Biden's kind of direction, that will stop the kind of zero-sum political discourse on repeal the ACA or try to chip away at it. It needs to be fixed. It does. There are problems in it. There are problems that exacerbate inequities of care. There are problems that create perverse incentives to, in different with different populations and in different states. The way the risk adjustment works in the ACA market doesn't work. There's a whole bunch of things, and it needs to be fixed through statute. It's stuff in the bill. The HHS and CMS can't fix it themselves, and so I'm hopeful that we'll get the kind of strengthen and improve bill that candidly probably should have happened 3 years after the ACA was passed. It should have happened when Obama was still president, but it had become such a toxic dialogue to talk about anything getting through both houses of Congress and through the president that builds on and improves legislation, which is how legislation operates. If something gets passed, it's imperfect, it has unintended consequences, and we try to fix it. And so we've just had this period for over 10 years where the idea of fixing it, of fixing the small things that are broken, has been off the table. And so everything that I'm hearing is, he's probably not going to try to make that a first 2 years priority. I hope he reconsiders and gets it done while there's enough focus on it, and we can move forward. I think that'll be the biggest. It'll be a bunch of small things, but a comprehensive piece of legislation that addresses some of the shortcomings in the ACA and strengthens it and makes it sustainable for the future will help us in our mission to provide high value care to the communities we serve.
All right, excellent. Next question. My group has been posting some job openings this past year and are looking to increase our staff diversity. While speaking with talent acquisition, we were told that we should specify that we are seeking diversity in order for that focus to be part of how the search is conducted. Why isn't this standard practice?
That's a good question. Actually, so it is now standard practice in our job descriptions. We have kind of template language that we drop in for that. So I will look into that and see if it's just probably not being communicated right. We actually I have two kind of high profile searches going on right now, and work to kind of craft the language that we now use for all the senior positions around leading with equity and the commitment to diversity. And so it should end up being standard practice. It may have just been them emphasizing to you that they want to make sure it's in the job description so that it's clear. Maybe they're just giving you a little bit more control than they should of whether you choose to include it or not. But thank you for raising that. I'll look into it.
All right, next question. Can you elaborate on the soft stuff, in quotations, that needs to be improved as it relates to burnout or resiliency?
Yeah, so ultimately, we need to be an organization where our people, our employees, our colleagues feel that we care about them and that we care for them. And the only way we can do that is by actually, doing that in everything that we do. And so when I say the soft stuff, it is it's everything from how do we create environments where challenges can be raised with no fear of retaliation. How do we create a culture by which everybody is given the benefit of the doubt, so that you can have dialogue about when you aren't feeling cared for, when you aren't feeling safe. So those are the sorts of things. So when I say soft stuff, I mean that kind of cultural change. Now, how do you do that? Right? How do you do that? Well, you do that by making that the expectation of leaders, right? And that's where you use the structures that exist in the organization to push that. And people need to be called out if they're not creating that sort of environment. People need to be let go if they repeatedly decide to not create that sort of environment. And we have work to do there. We need to, continue embedding that into the expectations we have of ourselves and of each other. But if we get to a point where, in the same way that I want every New Yorker to say that they trust Mount Sinai with their health, I want all 42,000 of our employees to say Mount Sinai cares for me, right? And we haven't earned that yet, but that's what we need to earn. And if we do that, I think that one of the side effects will be that is something that is worth doing in and of itself. One of the side effects will be less burnout and greater resiliency.
Excellent. So next question, and I think it ties into this from a leadership level. How do you recommend for employees to help their managers in anti-racism efforts? I think that Black, Indigenous, people of color employees are a bit exhausted, and having toolkits would be helpful, i.e., looking at data differently, understanding employees and their lives.
Yeah, so that is part of actually and Sean knows this, some of the work that we did, with the task force. I think one of the we have an issue, I think, as kind of where we are in our learning journey for many of our employees, where it creates an extra burden on our staff of color, because what happens is people are so early in their learning journey that they're saying, "Oh, I want to learn more," and then they're bluntly, they're turning to their closest Black colleague and saying, "Hey, help me learn more." And it's like, well, that's not that person's job. That's your job. You want to learn more. You need to learn more, right? Mm-hmm. And so I think you're spot on. You almost kind of answered it in your question, right? We need toolkits that allow it to be scalable. The education needs to be scalable, and I think that's it's part of the work that Diane Adams and Pam Abner are working on right now, actually. As it's probably no surprise to most of you, there's a bunch of stuff that came out of the task force recommendations, and there are a bunch of things that kind of started happening even before the task force report was finalized. And so I actually, spent some time with Diane on this earlier this week. Oh God, it's been a long week. Earlier this week, and some time with Pam on it last week, and what we're looking to do is exactly that: kind of create scalable toolkits to allow this education on what it means to be anti-racist, on specific behaviors that we're looking to see be spread across the organization rapidly and broadly, so that it's not just incumbent upon the employee to help educate their manager on it. And we also do need a safe way for the employee to flag that, hey, I think my manager could use some education on this. Right, and that should be part of it for sure. But it's a really, it would be a really backwards way of thinking about it if we said, hey, it's the job of X person to teach Y person about how they need to think differently as it relates to person X in the first place.
And the second part of the question was also, how does one at Mount Sinai become involved with anti racism equity work. And I mean, this is something that we're going to be looking for everyone to be a part of once the strategies and the roadmap is out there. I mean, me personally, I think if you identify with your local diversity council, that's a great start. I'm a part of the Corporate Service Center Diversity Council, which is sponsoring this event. And we talk about a lot of stuff. We have a lot of events and we do a lot of initiatives. I'm also a part of the Heritage Latino Alliance for ERGs. The ERGs do a lot of great work. They have a lot of tough conversations about a lot of things that are going on, whether it's inside Sinai and in the community. So, me personally, I think that's the great start. But unless you know another one, Niyum, that's where I would
Yeah,
start.
so I would say yes, absolutely, for that. And then the other thing is the expectation is going to be that everybody be involved in the anti-racism and equity work in their day-to-day job, right? And so that is, we are not going to get anywhere near where we need to until all 42,000 people believe that it is a core part of their job function, and that is critical. And if you want to do more than that, because everybody's going to be expected to do at least that, if you want to do more than that, then all of the things that Sean mentioned are great ways to get more involved.
Excellent. So we've got about a minute. You have time for one more because he's
Yeah,
still
sure,
answering the
absolutely.
easy question.
And okay, we'll take one more, and then I've got the answer to the movie question too. So
Okay, no problem. So, can you talk about allyship? As someone who is not black but is a minority and in a position of leadership, I'd be curious how that impacts your perspective contributions while working on things like the anti-racist task force and even day to day.
yeah, that's a really great question, and I think that probably one of the things I've struggled with on this one, candidly, is that so I am a minority, but I'm a overrepresented minority, um, and I come from a lot of privilege, and I've historically that's actually made me very uncomfortable because I don't have firsthand experience to identify with the lived experience of underrepresented minorities or of minorities who have faced other types of challenges that I haven't. And so that's again, historically that was harder for me. I think I now can kind of reconcile that a little better for myself, and and actually the language of privilege is one that is useful in that way of kind of figuring out how to categorize my lived experience. In terms of allyship, for me, and this is one person's experience, I have found that the best thing I can do is have open dialogue and encourage others to give me open feedback on the actions that I'm taking that are not consistent with allyship. And so it's one thing to say I'm an ally, which that's very easy to say. It's one thing to engage in some behaviors that are consistent with that whenever it occurs to me. That's also very easy to do. What is harder to do is to say, okay, I'm actually going to. It's the same point as kind of being anti-racist more generally. I'm going to look at the small decisions that I make, the decisions I make without thinking about it. And I've found that there's only so much of that I can do in my own head. I can make progress, but again, I've found that I really need to ask other people to call me out in a constructive manner, of saying, hey, that's not really consistent with what you're saying you believe in, Niyum. I was like, oh shoot, you're totally right, and then the next time something similar comes up, to address it. And so I think it's important to put yourself in positions where you're having dialogue with people who have different lived experiences, and I mentioned this to Sean in a note after our last task force meeting. He probably didn't know until I told him that, like, the things that Sean has shared in our task force and task force steering committee meet have educated me, and I've learned a lot from that. And for me, that's, again, selfishly tremendously valuable. It's great time spent when I get to learn from people like Sean, but trying to put myself in situations where I have more exposure to people of varied experiences and varied backgrounds teaching me has been, it's been probably the most helpful. But again, a lot more work ahead of me than behind me on that.
Excellent.
All right, the movie answer. It's a terrible movie, but I think it works. It would be Justice League.
Okay.
Because Mount Sinai is full of superheroes.
That's perfect. I think you picked a good one. That's perfect. Listen, Niyum, thank you so much for your time. This was a great conversation, as always, as we have had many so far. I hope everyone enjoyed this conversation. I hope everyone has a great weekend. And I want to thank ODI for organizing everything. And I'll leave you with this: wear your mask, people. It's safety. Thank you all. Have a good one. Thank
All
you.
right, thank you. Have a good weekend.
You too.